morning. I want to thank the organizing committee and Professor Mander for inviting me to this very interesting meeting and even very interesting subject. Then I talk about the antibody-mediated rejection. The antibodies directed against transplant are becoming recognized as a critical barrier to further improvement in the access of patients to transplantation and in the survival of allografts. Acute antibody-mediated rejection, about 20 to 30% of the allograft kidneys. Also, the chronic antibody-mediated form about 30 to 40% of all allograft. Allograft rejection caused by antibody directed against the donor-specific HLA molecules class 1 and 2, and the blood group ABO isoagglutinides. There is another non-HLA tissue-specific antigen. This is to the pigmentin, collagen 4, and the endothelial cell-specific antibodies. The target of endothelial cell antibodies is to the angiotensin type 1 receptor, the major histocompatibility complex, class 1 related chain A and B, the MICA and MICB. The cells of the immune system, the myeloid and lymphoid, and as we know, the myeloid giving the granulocytic and monocytic, and these give to the neutrophils, basophils, eosinophils, and the monocytic macrophages, Kupffer cells, and dendritic cells, and these cells are the major antigen-presenting cells. The other lymphoid, the T cell, B, and natural killer. The C cells form the T helper 1 and 2, and the 17 and the Treg are very important players in these conditions. The B cells can go into plasma cells, inflammation antibodies, and natural killer. The major histocompatibility pathway, it is important for the antigen presented cells, the antigen presented into cells in the proteosomes and then forming into prepared into prototype, and this is connected with a plasmid reticulum and to the major histocompatibility complex 1. And this is presenting on the surface to the T cell, and this important gene on the cell, the AP2. This is important for development of these peptides. The other part is the major histocompatibility complex 2. It is by the antigen presenting cells and forming processing the antigen, and the major histocompatibility complex 2 on the surface is combined with this processed antigen and then combined with the receptor on the T cell. Will lead to activation of the T cell with secretion of interleukin 4 and interleukin 5, and this activation will activate the plasma cells to secrete the antibodies. This is another way in which the resting or memory cell with the second hit antigen will transform into antibodies forming cells, the plasma cells. This connection between the T cell and the B cells need a ligands, the CD40 and ligand and the CD40 cluster ratio 40. This is important for their actions. And this will stimulate the B cell to get active and get formation of the CD20. These two are part of the treatment in these conditions. It was found there is a cluster of formation of the B cell, the CD20 on the peritural and in the glomerular and renal tissues. Another player for this mechanism is the complement. As you see here, the vessels and the endothelial cells, and it is presented on each surface the visual histocompatibility, and the antibodies in the patient sera will contact with this. This will stimulate the C1q, the complex, the classical pathway. As you see here, there is formation of the stimulation of C4 with the formation of C4D and C4A, and this 4D is important for the presentation on the blood vessels. And then the other classical alternative pathway will be stimulated with the formation of the C3A and C5A together with the mannose binding lectin. This important sugar can stimulate also the alternative pathway, the C3 and C5. This will lead to the formation of the chemoattractant substance, the C3A or C5A, and then the last part, the membrane attack complex of the complement, will attach on the cell and cause little stimulation, and then get thrombi and make a hole in this surface of the epithelium. All these can cause damage to the cell membrane and cell lysis. It was found that this C4D, which is the one of the complement said before, can be detected around the blood vessels of the pericular capillaries by immunofluorescence or by immunohistochemical studies. Also, they found that this 4D can bound to erythrocytes, and it was correlated mostly with the acute rejection present in these patients, and it was found it is more reliable than detecting the circulating C3D or C4D. As we said, the sugar moiety of the FC portion modified antibody function. If it is in the silation, FC silation, this will reduce the immunoglobulin cytotoxicity. But if it is glycosylated, as we see before, across FC receptors and complement pathway via mannose binding lectin, this potentially contributed to inflammation and energy. Also, the other player in this condition is a natural killer, expressing the receptor of C gamma R3 receptor for the immunoglobulin 1, G1 and G3. This is important for the antibody dependent cytotoxicity, complement dependent cytotoxicity, and it is played by the natural killer cells, and this is not specific to special antigen, but it is general and cause tissue damage. As we see here, this is the antigen, and with the antibodies combined on the target cells, and then this will stimulate the receptors on the natural killer, which is the CD16, and then activating the natural killer cell. This activated cell will contact with the others to excrete its substance, the interferon, gamma, tumor necrosis factor, interleukin 8, and macrophage inflammatory protein 1 alpha. All these can cause cytotoxicity and apoptosis of the cell. It was found that these receptors are presented on the tissue in patients with acute antibody-mediated rejection. The non-HLA antibodies, it is the ABO groups. It found, as Dr. Adel said, it is important on the surface and can be a barrier for the transplantation. But when it is desensitized and early, the patient can pass without any complications. But afterward, it is reappear again. But its reappearance will not cause any tissue damage. This because what we call the accommodation. Accommodation, it means no response, the presence of antibodies or no response to the tissue to these antibodies. This was can be due to the internalization, downregulation, inactivation, and inhibition of the target antigen. Because antibodies will stimulate the BCL2, which is the suppressor of the apoptosis. So we have here inhibition of resistance to apoptosis. The anti-endothelial cell antibodies is found by the microarray studies and endothelial induction of endothelial gene expression in kidney transplanted biopsy with donor-specific antibody detected in acute antibodies-related rejection. And this predict the prognosis of the tissues. This endothelial gene expression transcripts the von Willebrand factor, the caveolin, the E-selectin, CD31 and CD34. Also, the apoptotic endothelial cells release a bioactive substance, the LG3, This CLG3 as an antigen will have an antibodies. And these antibodies of the anti-LG3 will recruit and bind recipient leukocytes and increase a potential graft inflammation. Also, the stimulus of B cell stimulus factor, stimulating factor, or stimulating molecules was shown to be present in a soluble and increased during the rejections. And it was found that in the presence of anti-endothelial cell antibodies in patient, the graft survival would be decreased in comparison with the patient without endothelial cell antibodies. Also, there is another substance, immunoproteasome beta subunit 10. This subunit is important for antigen processing for presentation. And it is important and can differentiate between the chronic antibody-mediated rejection and other histological features of the same condition. And it's very sensitive and specific, as we see here in the ROC curve. Another gene expressions on the cell, the endoglin, the CD105, and the FLT3, it is one of the tyrosine kinase. These are important for the initiation and processing of the antigens, and it is found on glomeruli and the peritubular papillary in patients with acute rejection. The prerequisite to diagnose acute antibody mediated, we have three categories. Number one, the histologic manifestations, the microvascular inflammation, the intimal and or neural arthritis, acute thrombotic microangiopathy, or acute tubular injury in the absence of a known cause. Also, the other one is the presence of CD4 staining on the peritubular capillaries. The last one is the serological markers of the presence of donor-specific antibodies in the circulation. So the diagnostic criteria, as you see here, is CD4 positive. The serological, the histological, and the immunological. There is another part, we call it the patient in acute rejection, but without this CD4, the negative CD4. The same serological and histopathological, but no this immunopathological. It was said that there is an endothelial activation and increase in the messenger RNA expression of the endothelial genes. It is not antibodies, it is the genes that against the component of the endothelial cells. The chronic antibody mediated, before it was called chronic rejection due to its immunological basis. But after that, they found that another factor, non-immunological factor, and it was called chronic allographic nephropathy. That is its main presentation, the interstitial fibrosis and tubular atrophy. But due to the recent or the known that there is another factor, the antibodies against these chronic manifestations, so it was called the chronic antibody-mediated rejection. And it was at least the non-immunological could be due to iatrogenic or the decrease in the immunosuppression due to iatrogenic non-compliance or malabsorption. And it is due to the de novo presentation or reformation of the donor-specific antibodies. And it was this donor-specific is important as it is present, the 60% of these grafts will be survival, if not present, about 90% of the survival. The course of these antibodies or these patients with this graft, in the early stages, there is no antibodies. But in phase 1, there is de novo formation due to any of their previous causes, formation of antibodies. But this will not cause any clinical or histopathological. By the time they start to appear the CD4 on the vessels, but without any other histological presentation. By phase 3, this we call accommodation. As we said before, this is accommodation, the presence of the etiology, but no affection. After that, phase 3 and phase 4 start to get the pathological, and then in stage 4 we get the clinical presentation of disturbance, renal function, and the other conditions. And was present that patient was de novo donor-specific antibodies formation, there is less in the graft survival than the controls. So the pathological lesion of these, the first transplant glomerulopathy with double contouring, vascular changes, destruction of the elastica and inflammatory cells, and the other microvascular formation. So also in the chronic allograft antibody-mediated graft rejection, we have the CD4. This is a component, the CD4 with immunology on positives have antibodies, donor-specific antibodies, the immunological, the CD4 on the vessel peritubular, and the histopathological, as you will see, the glomerulopathy, the tubular basement membrane, multi-layering, and so on. There is another part with negative. The same, it's serological and histopathological, but here also, as in the acute, there is no CD4 on the staining, but there is endothelial activation of the different genes. This is the transplant glomerulopathy, as you see here in the light microscopy. This is cellular infiltration on the peritubular and glomerular, and here the C4D deposits around the vessels. This is a presentation of the layering, of doubling of the glomerular vesicle membrane, and here by the electron microscopy, there is an increase in the subepithelial area and doubling or separation of the glomerular vesicle membrane. This is the peritubular multi-lamination. As you see here, the vessels have multiple layers. By this CD4 negative patient, it was found different gene expression profile of endothelial activation and energy. We call it endothelial activation and energy transcripts and donor-specific associated gene transcription. About more than 100 genes was discovered in this condition and correlated with the pathological and clinical condition of the patient. We have definition. Hyperacute rejection, it is due to preformed antibody. Early acute related rejection, it is due to the amnestic antibody response. Late, due to the de novo donor-specific antibody production. The chronic recall of the secondary is already present and suppressed, but for any reason it reactivated. Or a mixed, or that accommodation, that's the presence of the antigen and the antibodies without any injury of the tissues. This is the acute, hyperacute rejection with arteriolar thrombosis. This is the acute mediated antibody rejection with the perivascular inflammation with capillarities. So to diagnose these, we say depend on the histopathology and the presence of circulating antibodies. How to detect these circulating antibodies or anti-HLA antibodies? This could be with a cross-match, complement-dependent, cytotoxic, and it is sometimes the patient have acute rejection with a negative cross-match. But this detecting only the complement-fixing antibodies, cannot detect the non-complement fixing antibodies. The mixed lymphocytic and primary active antibodies.
Dear doctor, your time is up.
Can we allow just a couple of minutes, please?
Okay.
Organize يا جماعة الكمبيوتر
فتحت. The solid phase antibody is important for testing the antibodies. This is example of the anti-HLA, and this is the flow can be detected across match by flow cytometry. It is more sensitive and more specific. Also, the solid phase, this is important. It is do not need the cells, and it is more sensitive and can detect the anti-fixing complement and non-complement fixing antibodies. And this can be detected by ELISA or by flow cytometry and by Luminex. The C1Q assay, also the one of assessing underproteomic, as was said before in the morning, can be used. And this is the comparison between the three methods, and we know that solid phase, this is one the more sensitive and more, but it is expensive, but can detect the individual antibodies to the patient. Thank you very much.